Hello and welcome to this conversation on Medics Voices. Today I'm talking to Dr. Gordon Caldwell. Now, many of you will know Gordon on social media because of that famous photograph illustrating the amount of paperwork admitting a patient with diabetes to hospital. But Gordon has much more interest than that, and he's really a lot of experience in managing of patients and the human side of medicine. But first, you better tell us about that photograph.
Yeah, I was getting increasingly frustrated on ward rounds, battling with piles of nursing paperwork and trying to find out answers to things like the patient's weight and the most recent blood glucose. So I asked the charge nurse on our ward to give me one piece of paper, one copy of every piece of paper that the nurses had to fill in to admit a patient to a general medical ward. It was going to be a diabetic patient who needed intravenous antibiotics. So Kirstine gave me all those sheets of paper. I was thinking of sticking them on the wall, but then decided I'd just lay them on the floor in my office. And Lindsay, my secretary, came in and said, "What on earth are you doing?" Told her. And she said, "Well, why don't you just lie down on the floor and I'll take your photo to give some sense of perspective to it." So that's how the photograph came about.
It really is a remarkable photograph. And we've seen different photographs of people with books piled high of guidelines on how difficult it is sometimes just to navigate the health service because of your bureaucracy. But let's take it back a little bit. Tell us a little bit about your own personal career.
Well, I trained in Oxford for 3 years and then went to King's College in London, qualified from there, worked there for 6 months, and then down to Brighton for a few years, up to Edinburgh, where I studied endocrinology, back to the postgraduate medical school in London to do some diabetes research, a senior registrar job in Newcastle, and then down to Worthing, where I became a consultant in 1993, worked there through till the end of 2017, and then spent 4 years working on the west coast of Scotland in Oban as a consultant general physician.
Well, that sounds all very structured and organized, but what really interests me is your work on the human side of medicine, because this is a particular interest. Tell me a little bit about that.
Certainly the curriculum at King's College in London was very much based on Osner's principles, going back to Boerhaave as well, that the learning and the teaching came from being with the patient and seeing the patient and understanding the patient and connecting with the patient was what drove my learning. It was because I'd met the patient, I wanted to understand how to interview and examine the patient, then how to make a diagnosis and to treat and manage the patient. So I think the learning comes from that, to me, essential component of being a doctor, which is professional human relationships. So we have to know the person if we're going to treat the person. So I think really with every patient, and one of the things I try to teach every student of mine and every junior doctor is find out who the person is before you start treating them as a patient. So unless the person was unconscious in A&E, I always started with, remind me how old you are, what is or was your job, what interests you, and what do you enjoy these days? And that creates a very strong connection very quickly, from which then I can remember the patient. And often I'd use that sort of information as a memory hook for the whole of the case. But it's beyond a memory hook. It actually creates the connection as well.
What I heard you speak about once, and it really struck me about your kindness, and that is when you asked a patient what they would really like, and they said they would like an ice cream.
A middle-aged gentleman had been admitted with advanced pancreatic cancer. And when he came to the bedside, it looked like he was dying fairly imminently. So I felt rather useless, in a sense, towards the end of the consultation, because the nurse had addressed his pain very, very well, and he looked comfortable. And I said, "Well, is there anything we could do for you?" And he said, "I'd really like an ice cream." And that student nurse, in her break, went to the hospital shop and bought him an ice cream, brought it back to him. He ate the ice cream after his lunch, and then he died. And I just had to commend that nurse to the sister for her humanity, seeing that that's what the man wanted, doing her extra little bit for it, coming back. So when he died, he just had the thing that he wanted. That just struck me as what medicine and nursing, we've got all that science and all that ability to relieve the pain, to make the diagnosis, do all the scans and biopsies, but there's still humanity in it.
What also struck me is the way that you've joined up those different parts, from the humanity to the technology to the organization. I think you described it as paying attention to the ordinary.
Yes, yeah. Well, on that, the point I was making really was that doctors tend not to think very much about ward rounds because they're so ordinary, and yet the reputation of international companies is really set on what they regard as ordinary and doing their ordinary work very, very well. So the reputation of Volkswagen was built on the Beetle and the Golf, not on top performing sports cars. So I wanted to concentrate on ward rounds and the events that were going on in ward rounds because they're so ordinary that generally people hadn't even thought about them. How do we go about organizing? What's the process? How do we maintain safety, teaching, humanity within the context of that very busy, pressured environment?
Again, one of the other things in medicine, when we have all this talk about the academic side, another of your interest is quality and safety.
Mm.
Tell me about quality and safety and how we can integrate that more into healthcare.
Well, as you know, remember Lord Darcy was talking about a lot about quality and safety. And when I was reading that, I didn't quite understand what it meant at the point of care. And then I was increasingly aware of the mistakes that were made within my team. I can remember we had 2 patients within a fortnight who were given intravenous coamoxiclav, both known to be allergic to penicillin, and both nearly died of anaphylactic shock. And they're both wearing red wristbands. So it's what was going on, that things were going wrong. And that's when I started reading about quality and safety, particularly in the airline industry, and that safety is no accident. And yet I wasn't really doing any active patient safety checking. So there are all these different initiatives going on, like, have we identified whether somebody's at falls risk? Is the prescription chart legible? Have they had their VTE assessment? A whole lot of aspects where I thought it would be better if we were active and went through a standard process with every patient. And that particularly came to light after I allowed a foundation year 1 doctor to lead a ward round when she saw 25 patients in the morning, I think. And at the end, we asked Claire what she thought of it. And of course, we've been supporting her and helping her all the way. And she said she felt supported and helped, but she didn't know if we'd done everything. So that was a Monday. I said, come back at Wednesday and let's all discuss what we think doing everything for every patient is. Have you checked they've got a cannula? Have they checked they've got a catheter? As well as have you checked they've got the correct diagnosis? And on Friday, we had our first checklist and said to the medical student, we've decided we're going to do all these things for the patient. You've got to watch out and see whether we've done them. And that's really started this whole thing about what I'd call active patient safety checking. And it can be really quick. The sort of thing is, have you been are you eating and drinking? Have you been walking around? Have you got a cannula? Have you got a catheter? Have we checked your VTE prophylaxis? Have you got any wounds and dressings? And just making it into a standard process, which is really multidisciplinary, then you could come away from the patient thinking, we may not have made all the right decisions, but we've made all the decisions we have to. And we've looked at everything. And we can go away and think we did a thorough job. So that was where that sort of bringing quality and safety right down to the patient side and making sure that the patient would feel secure, we'd feel secure, we'd know we'd done a good job, done it well, and completed everything.
Now, there's an interesting challenge there for medicine, because now, listening to your career, you've been in so many different hospitals and so many different locations and worked with so many different people. And of course, that's what the consultant would say, they like their individual approach. Mm-hmm. But actually, yes, the checklist means a generalized approach. Mm-hmm. How can we integrate the sort of individualism with the generalist checklist approach?
Well, I think it's, in a sense, what I realize, it's not a checklist, it's a process. And if you've got an important process, then we usually check up on it. If you're getting ready to go on holiday to America, you check you've got your passport and you've got your credit card and your telephone with you and you've got your clothes. So it's a natural thing, I think, to check the process. And what I was very keen to do, what I didn't want to influence people's diagnostic thinking and their conclusions about what the treatment was, because we all know every cardiologist will choose a different medication for atrial fibrillation and have a different attitude to anticoagulation. I wasn't going to try and influence that. I was just wanting to make sure that whatever medication they decided on was written up and legible, and everybody knew who had done the prescription, and that it was all being administered. And all their good work on managing that wasn't undone by somebody forgetting to take the cannula out of the arm, and they get sepsis and bacterial endocarditis because we forgot to take the cannula out. So really, I was just wanting to, I think the change I was making was to bring in some active safety thinking into the process, rather than what I always used to do on my ward rounds before then, tip up at the bedside, look at the diagnoses, think we'd covered everything and go away. And I remember the first few weeks that we were doing this, we found we were appalling at checking for cannulas. We're really bad at checking for urinary catheters, very bad at DNA CPR decisions, sealing of care decisions. We thought we were good at it, but we suddenly found that we weren't, because we're following the process. And the person, the medical student, was saying, we haven't done these things. Particularly, I remember that we decided we must communicate with the nurse after we'd seen the patient. And I remember my registrar, Umo, and he would say, Dr. Caldwell, you haven't spoken to the nurse yet. We've got to go and find the nurse. And we'd end up walking all around the ward to find the nurse, to talk to her and say, we've just seen the patient. All this must be done.
I was very interested the way you changed the responsibility in that ward round due to the FY1, to the foundation round. And also you spoke about the medical students. So finally, what is your message for the medical students of today?
Well, of course, the first thing is get to know the person. And I'd say right at the beginning, get to know the person before you make them into a patient, get that human connection. And then, I think the students who came on our team loved being on the team because they had a role and they had a voice and a responsibility. And I'd love to actually see my colleagues using these approaches, so that the medical student on the team is viewed as an essential component of the team. And I always found it much better when I had the medical student there. And then because they're speaking, they'll ask questions, and then we can talk about the science of medicine as well. So I suppose, what would I say to them? Yeah, medicine's still a great career as long as we're allowed to practice medicine.
Thank you very much. It's been an absolute pleasure talking to you, and thank you for sharing your wisdom and experience and that beautiful human side of medicine. Thank you very much indeed.